Shingles, also known as herpes-zoster, is a viral infection caused by the reactivation of the varicella-zoster virus, VZV, the same virus that causes chickenpox. After recovering from chickenpox, the virus remains dormant in the dorsal nerve root ganglia of sensory cranial and spinal nerves. When the immune system weakens due to aging, stress, or illness, the virus can reactivate, leading to a painful rash that follows the path of the affected nerve. The condition is contagious to those who have never had chickenpox or the chickenpox vaccine, potentially causing them to develop chickenpox, not shingles. Although shingles is caused by VZV, it is different from herpes simplex virus, HSV, which causes cold sores HSV1 and genital herpes HSV2. Shingles is diagnosed through visual examination, a zinc smear, or viral culture. Assessments, best interventions, and core rationales. To begin with, when assessing a client with herpes-zoster, you may notice vesicles along the peripheral sensory nerves on the trunk, thorax, or face. These skin lesions appear unilaterally in clusters. Because of this, it is crucial to maintain standard precautions and implement contact precautions for as long as the vesicles remain. The reason is that the fluid inside the vesicles contains the varicella-zoster virus, which can be transmitted through direct contact. By taking proper precautions, you can prevent the spread of infection to others. In addition to skin lesions, the client may develop fever and malaise. At this point, you should assess for any additional signs of infection, including skin and eye infections. This is important because fever and malaise indicate systemic involvement, and if left unchecked, secondary bacterial infections may occur. For this reason, early detection is essential for timely intervention. Moreover, clients often experience burning and pain, which can be quite distressing. To help manage this, providing an air mattress and a bed cradle while maintaining a cool environment is recommended. Since warmth and touch can aggravate the pain associated with herpes-zoster, a bed cradle prevents pressure from blankets, reducing discomfort. As the condition progresses, some clients may report paresthesia, which is an abnormal sensation such as tingling or numbness. At this stage, it is essential to assess the client's neurovascular status and evaluate the function of the seventh cranial nerve. This is crucial because herpes-zoster can lead to complications like Bell's palsy, facial nerve paralysis, and other neurological deficits. By identifying these complications early, healthcare providers can ensure timely intervention. Furthermore, many clients experience pruritus or itching. In such cases, it is important to prevent the client from scratching or rubbing the affected area. Otherwise, scratching can cause skin breakdown, which increases the risk of secondary bacterial infections and delays healing. Additionally, they should wear lightweight, loose-fitting clothing to minimize irritation. Materials like wool or synthetic fabrics can be harsh on the skin and worsen discomfort. To further promote healing and comfort, astringent compresses may be prescribed to help with irritation and pain while also encouraging crust formation. Patients should also be taught the importance of keeping the skin clean to prevent secondary infections. Lastly, prevention is key. The shingles vaccine is recommended for individuals 50 years and older to significantly reduce the risk of developing shingles and its associated long-term complications. For shingles vesicles, the appropriate dressing depends on the stage of the rash and whether the lesions are open or crusted. For open vesicles, moist non-adherent dressings is used such as non-adherent gauze, examples, Adaptic, Telfa, prevents the dressing from sticking to the blisters and minimizes pain when changing it. Sterile hydrocolloid or hydrogel dressings help maintain a moist wound environment, promoting healing and preventing scabbing. For crusted lesions, it is better to use a dry sterile gauze, used once vesicles have dried and crusted over to protect the area from irritation. For medicated or cooling dressings, an astringent compresses is used such as Burrow solution or Domburrow soaks. This helps dry out vesicles, reduce inflammation, and relieve itching. A cool, moist compresses will soothe discomfort and prevent excessive dryness. The primary medications for shingles, herpes-zoster, include 1. Antiviral medications start within 72 hours of rash onset. Acyclovir, Zovirax, given orally or IV in severe cases. Valacyclovir, Valtrex, more effective and requires fewer doses than acyclovir. These help reduce viral replication, speed up healing, lessen pain, and lower the risk of post-herpetic neuralgia. 2. Pain management. Since shingles causes nerve pain, various pain relievers may be prescribed. NSAIDs and acetaminophen for mild to moderate pain. Opioids for severe pain, if necessary. 3. Medications for post-herpetic neuralgia. If nerve pain persists after the rash heals, gabapentin, Neurontin, or pregabalin lyrica is given to reduce nerve pain and tingling sensations. 4. Corticosteroids, used with caution. Prednisone is sometimes given with antivirals to reduce inflammation, especially in severe cases like herpes-zoster ophthalmicus. 5. Antiviral eye drops, for eye involvement. Trifluridine and corticosteroid eye drops are used. 6. For pruritus, a calamine lotion, astringent compresses, oral antihistamines such as diphenhydramine, Benadryl, are often prescribed to the patient. Possible complications include post-herpetic neuralgia, a persistent nerve pain that lasts for months or even years after the rash has healed. This is the most common complication, especially in older adults. Secondary skin infections. Ophthalmic zoster occurs if shingles affects the eye. Neurological complications such as Bell's palsy, hearing loss, and vertigo. And in rare cases, a disseminated herpes zoster in immunocompromised individuals, wherein the virus can spread to multiple organs, such as the lungs, liver, and brain.